Hello and welcome to today's webinar, Data-Driven Improvement on Time-Sensitive HEDIS Measures. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available within 1 to 2 business days. Should you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box, which is located on the right side of your screen, and pressing Enter there. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Stephen Berkow, Senior Advisor for Value-Based Care at InterSystems, along with Kate Beck, Assistant Vice President of Health Information Exchange, and Autumn Kerr, Assistant Vice President of Clinical Quality, both with Healthfirst. And at this time, I would like to turn the floor over to our speakers.
Thanks, Chris. We are going to spend a little over the next half an hour but hopefully effectively unpacking how Healthfirst leveraged InterSystems technology to achieve these results. And each of these results represent a documented improvement on a specific time-sensitive HEDIS quality measure. And collectively, they were recently acknowledged by class with a 2025 Points of Light Award. So for people who want to go deeper into this story after the webinar, feel free to go to intersystems.com and download the case profile. Now, achieving improvement on time-sensitive HEDIS measures has proven a national challenge because of widespread lags in claims processing data. So typically, the clock for a time-sensitive HEDIS measure starts ticking as soon as a patient, typically a high-risk patient, is discharged from a medical facilities. And what HEDIS calls for is pretty prompt follow-up care for these patients, customarily within 30 days or less. And if you move to the far right, you can see the challenge for health plans who are relying on claims data to basically ensure prompt follow-up care. For a care manager at a health plan relying on claims data, typically they're not aware that a qualifying event has occurred until after the window for the needed follow-up care has already closed, which got Healthfirst thinking, why not instead use real-time clinical data feeds to close these time-sensitive care gaps? And with that, I'm going to turn it over to my colleague, Kate at Healthfirst, to introduce her plan.
Great. Thank you, Stephen. All right. Hello. Hello, everyone. Thanks so much for joining us today. My name is Kate Beck. And before we start discussing our work on the time-sensitive HEDIS measures, I wanted to spend just a few minutes to tell you about Healthfirst as an organization. Oh, Stephen, can you go back one? So Healthfirst is the largest not-for-profit health insurance company in New York State. We currently have over 2 million members across New York's downstate region, which includes New York City and Long Island, as well as some membership up in the Hudson Valley. We offer a variety of plans for our members that span Medicare, Medicaid, long-term care, qualified health plans, and the essential plan. We are primarily a value-based health plan, and over 80% of our 2 million members participate in some kind of value-based arrangement. We were founded over 30 years ago by 15 of the leading healthcare systems in New York City, and today those health systems act as our hospital sponsors. And it's really that sponsor model that I think sets us apart from the other health plans, because the model really emphasizes and incentivizes close collaboration with providers. And that collaboration really promotes health equity and improved health outcomes for our members. And you're actually going to see that collaboration in action today as we get into the HEDIS work in just a few minutes. But before that, I'm going to pass it back to Stephen, and he's going to tell you a little bit about InterSystems.
So InterSystems is a global leader in healthcare interoperability with special expertise in integrating clinical data from disparate sources. On the slide, what I've done is just kind of included a snapshot of the healthcare organizations we serve across North America. If you look in the middle, you can see that we have a deep commitment to supporting health plans, a wide range of health plans. And so in addition to our solutions for helping health plans improve HEDIS performance, we also have solutions for electronic prior authorization, payer-to-payer data sharing, and just more generally, a host of solutions for advancing value-based care. Again, if you're interested in learning more about us, intersystems.com. Again, what I really want to focus on is our case study today. And one of the things I really like about this story is it's not an isolated initiative. It's actually just a chapter in a larger and I think pretty thoughtful health IT strategy. On the slide, it's just the timeline of the partnership between HealthShare and InterSystems. And I'm not going to go through every element. I'm just going to call out just a couple of key dates to get us going. So you can see we've been at this together for roughly a decade. Healthfirst first came to InterSystems and said, can you help us build and support a private HIE to support the bidirectional flow of data between Healthfirst and its network providers. And then if you start to move right, you can see a few years later, a more common use case coming into fruition. So Healthfirst starting to leverage that data through its HIE to document the closure of HEDIS gaps, around 20 if you drop down to the footnote. But Healthfirst, kudos to you guys, said, look, we don't want to just leverage this data to document the closure of gaps. We actually want to start to use this real-time data to enable better care. So in the middle, you can see it started off, like many things do, a limited pilot, going after one time-sensitive care gap. And then just a couple of years ago, Healthfirst came to us and said, you know what, we're ready. We want to scale this thing. We want to go after multiple measures across our entire population. And we thought that was a great and worthy idea. And I'm going to hand it back to my colleague, Autumn, to go a little bit deeper on why we all thought this was so important.
Thanks, Stephen. Hi, everyone. So as Stephen mentioned, I'm going to go through the measures that we're going to talk about today and why we chose this type of measure for this project. So the measures that we're going to be discussing are follow-up after emergency department visit for members with mental illness or FUM, transitions of care, particularly the medication reconciliation post-discharge component of TRC, and follow-up after ED visit for substance use or FUA. What all of these measures have in common is that they all have a really short window required for follow-up. As you can see here, they have between a 7 and 30-day window, and this is the time frame that members need to get back in for follow-up care. As Stephen mentioned, right, we're unable to rely on claims to be able to identify the denominator in time in order to fulfill this requirement. So we had to come up with an innovative solution, and that's where our private HIE came in. We receive near real-time alerts through the admissions, discharge, and transfer or ADT process that allows us to predict through the place of service and the diagnoses that come in which of our members may land in these denominators. What we did was we took that information and we collated it into reports and consolidated them and sent them back to the provider of care. And this enabled us to ensure that those providers had as much time as possible to fulfill that 7 to 30-day window. And finally, and I think most importantly, the members that land in these denominators and have these open care gaps are our highest risk and most vulnerable members. And we want to make sure that we're providing our providers ample amount of time to recall these members in for care, we want to avoid future readmissions, future visits to the ED, and make sure that they're getting the timely follow-up that they need, not only to close the care gap, but for their own well-being. So now that we went through that, I'm going to pass it back to Kate, who's going to walk through the process that we developed in order to get this into action. Kate?
Thanks, Autumn. All right, so the success of this program, I'll just start by saying, is really very much due to collaboration between our technology partner, which is InterSystems, but also our internal technology and quality teams, and of course, the providers who engage with our members. And working together, we're really able to support the identification, the communication, and then the utilization of the HIE data to support health outcomes and close care gaps. And so the whole process really starts there on the left with our private HIE, and we leverage HealthShare to ingest all of those ADTs that Autumn mentioned that are coming in from our connected providers and our public HIE partners, of which we engage with 2. And so we have really on the HIE side about 300 connections, which represents and provides data across over 1,000 different practices in the downstate region. And so on a daily basis, we're really processing a lot of data. And so HealthShare really helps us ingest all of that data, and then also has automated the identification of all of these HEDIS qualifying events. And most of these events, as Autumn mentioned, are triggered off of an acute discharge. So it's either an ED or an inpatient discharge. But a lot of the measures also have additional triggering criteria, which include qualifying diagnoses or participation in one of our particular health plans. And so moving towards the middle there, once we identify the events, our next step is to identify the appropriate provider to inform. And it really does depend on the measure where we've chosen to send the notification. For some measures, we'll send the notification to the member's primary care provider. For other measures, we'll send it to the discharging facility. And there's actually a couple of measures where we will send it to both the PCP and the discharging facility. And so once we've identified where we want to send the notification, we then bundle up the details of the event, along with some reminders about the specific measure and what follow-up care is needed. And then we send that off to the provider. The notifications are sent Monday through Friday, and we actually send them via encrypted email, which is a pretty simple delivery mechanism, but we've actually found that it works very well and really suits many of our community providers and their sort of level of IT sophistication. And then moving to the right, lastly, once the providers receive the email, they incorporate the details of the notification into their own daily panel management activities. And then they do the necessary outreach and follow-up with the member that's going to ensure a healthy outcome for the member, and then also close the care gap.
All right. I'm going to go through the collaboration points that we need to work through. As you can imagine, there was a lot of collaboration between us and the payer. We are the payer, us and the providers, in order to make sure that we were both comfortable with what we were sending, what we were doing. So I'm just going to go through that. The first thing that we did was identify the barrier that we were trying to solve for. Right? We knew that window of compliance was short, and we needed to make sure that we got this information back to those providers and they had as much time as possible to close the care gap. The second thing we had to do was sync our workflows. What information were we going to be sending back in these reports? We had to balance that between giving them the right amount of information without overwhelming them with too much. What we did settle on was sending the reports every Monday through Friday. And we actually, a little while in, we determined that we weren't getting the amount of data we wanted sending back. So we actually instituted a 72-hour look back, which means every Monday to Friday, we don't just look at the alerts that came in the day before. We go back 3 days to ensure anything that may have been closed out within that time period was also sent over. And we found that when we did that, we actually got a lot more of these alerts and events back to providers. And then the next was, how were we going to display this information? What information were we going to display? We decided on the appropriate level of member demographics. and event data to send back. And it comes in an attachment in an Excel format. And then embedded within the body of the email is the reminders of what the measure is and what is needed in order to close the measure, right? The time frame needed, the type of visit, and the information they need to get back to us. So, we did, right, the value-based arrangement that Kate had mentioned that we have with our providers really did enable this level of collaboration with them. We were able to go back and forth and iterate on what we were going to send. Is this too much? Would you like this? Until we came to a comfortable solution and an area that we really feel has led to the success of our program. And speaking of the success of our program, I'm going to jump into that next. So we're really proud of the results of this program, as I'm sure you can hear and understand. We have been tracking our results for quite a few years now, and the one thing that remains the same year after year is that members who've had their events emailed on versus those who have not have significantly higher compliance results. As you can see, right? Listed are the 3 measures I talked about earlier, and they have either a 33 or a 34% increase in compliance, right? So you'll see the smaller number is those members who did not have their events emailed. The bigger number is those who have. So these 2 things that we're really proud of, right? As a result of this program, for these 3 measures alone, over 5,000 Healthfirst members have received timely follow-up care. And then in addition to that, we've been able to alleviate the administrative burden on our providers and hospitals, where they would have to go into their systems, find all the Healthfirst members, do all that. We're doing it for them, so that enables them to focus on what they do best, which is patient care. That's where we want their focus. We're going to do what we can to alleviate that burden and allow them to focus on our patients and members so they get the best care possible. Stephen, did you want to add anything?
Yeah, I just wanted to give people a sense of how this compares to national benchmarks, because I think it really is important to underscore that they took, good performance. I never want to say great because there's always room for improvement, but they made it really, really good. So just some of the most recent benchmarks we have in terms of how our Medicaid and Medicare HMOs functioning on FUM and FUA for FUM. Pretty much the benchmarks for average performance are 42% and lower. And for FUA, it's 25% and lower. So I just do want to laud my colleagues here publicly that this isn't a story where they started at a bad point and then did well. This is actually a story where they started at a really, really strong point and did better, which again, I think underscores what Autumn is talking about, that we've really got to figure out a way to have more timely alerts, and clinical data feeds are really obviously a promising way to do that.
Because we never rest, Kate's now going to go over next steps and how we're planning on enhancing and improving this process and project in the future.
Thanks, Autumn. Correct. And I want to reiterate what Stephen had said. We measure this program constantly from many different angles and are always identifying sort of incremental opportunities to improve it, and have seen that incremental increase in impact over the years. So that's sort of an ongoing activity that we do. But in terms of, beyond that, what is next for the program? So I think first and foremost, we do want to grow the program. We obviously know that it works, and it works really well for us and our providers and our members. And we know that there's also opportunity with other time-sensitive measures. So we have identified, which we posted on this slide, is the next measure that we're targeting to include in this program. That will be FUI. That's follow-up after high-intensity care for substance use. And that will actually be the 9th measure that we have in this program. Secondly, going back to measurement, we always want to make sure that we're identifying as many of these events as possible. And so we closely monitor it's like a weekly, monthly basis, all of our provider feeds to ensure that they're sending us in a timely manner all of these events, these ED and inpatient discharge events. And then not only just sending us the event, but making sure that they're including all of the diagnoses associated with those events so that we can accurately identify them for the specific HEDIS. And then lastly, we do want to make some improvements in how we deliver these notifications. I had mentioned that we send them via encrypted email, which does work very well for many of our providers. However, the program, we started with one measure. We've since grown it. We have 8 in production today. And as a result of that growth, which is great growth, some of those providers do end up getting multiple emails on a daily basis that's supporting, individual multiple measures. And so those multiple emails, it tends to get a little bit noisy for our providers. And so we are looking at doing some consolidation of those emails to be able to send multiple measures through a single email. So that's something that we're going to push live in a couple of months. And then I also think there's a lot of opportunity in the future to be able to deliver these notifications directly within the clinician's EMR. I know some of the EMR products will support that, so that's another avenue that we're exploring as well. And so I think, those are the main things, on the horizon for the program. And I think that really wraps us up for today. So I think, before we turn it over for questions, I just want to say thank you to everyone for joining. And Chris, do you want to take it from here?
Great, thank you so much. At this time, like as said, we're going to go ahead and address some of these questions that came in during the presentation. So the first question is, what is HealthShare?
Stephen.
That's a great question. So InterSystems is the company, and HealthShare is the platform that we provide to our plan customers to support interoperability. And whoever asked that, I just want to thank you for the softball to get going here.
All right. Another question is, what prompted Healthfirst to create its own HIE, and how did you leverage HealthShare to do this? And the follow-up question there is, why did you connect to a public HIEs a few years in?
All right, so I'll take this question. So we, it was over 10 years ago where we decided to stand up our HIE, and it was really as a means to connect with our, not only our sponsor organizations, but also our, our broader, I think, provider community. But really because we have always been a value-based company, sort of understanding that this collaboration and sharing of data benefited both us as a health plan and our providers, and ultimately our members. And so I think that was the real driver, and also really as a means to get data for the quality was really the first case that we used the HIE for. HealthShare was a very strategic partner. I think we were, if not the first payer, one of the first payers with InterSystems using the HealthShare product, and so they were extremely collaborative in sort of developing and help developing the platform, I think, to support the payer use cases, and also helping develop our own thought processes about how we could use HIE to support us as a plan. I think there was one more question there at the end. Could you repeat that one?
Sure. Just let me go back to it. Why did you connect to a public HIE a few years in?
Oh, great question. Yeah, so we actually connected to Healthfirst, which is the largest public HIE in New York State, right as the pandemic actually kicked off. And we did it really as a means to augment our direct connections. Healthfirst is connected really essentially to all of the inpatient and ED facilities across the state. And so we could connect to one organization, Healthfirst, and actually get data from hundreds of different health systems across the state. So it was really a sort of access to a large volume of data for us.
Okay, the next question is, how would this work for health plans that don't have an HIE, or how would it be different?
I can take that, and then Kate,
sure,
please add on. I think the real question is just how good and how broad is your data source. Again, going back to what Kate and Autumn said, they're provider sponsored. They have a really strong relationship with their network providers, so they were able to tap into a lot of information through their private HIE. If you're in a situation where you're getting a lot of, if you're in a region or an area where you have a really strong public HIE, you can do the same thing. We give you tools, and we partnered with Healthfirst on them using our tools to write the if-then equations in effect to identify the qualifying events. So it's not really whether it's private or whether it's a public HIE. It's just, do you have enough incoming clinical data streams to do this? I don't know, Kate, if you want to add to that.
No, I'll just say again, like the public HIEs, they can deliver a lot of these alerts. So as long as you have an internal process to be able to ingest them and identify how you want to use them, I think the private HIE platform is very much an added bonus, but not a requirement.
Right. Another question asks, what parts of the process are now fully automated versus partially automated versus still manual?
So I'll take that one. So the process is actually primarily automated. So certainly the ingestion of data, identification of events, and generating and sending out those email notifications, it's all automated. I think where it becomes potentially more partially automated or manual is when it gets to the providers, and different providers have set up different workflows when they receive these emails. I think some, maybe more sophisticated practices or IPAs will ingest the alerts into like a panel management platform or care management platform, whereas maybe smaller practices are just opening up the email and working directly from the attached spreadsheet.
All right, someone is wanting to know, what methods did you use to determine which members should be included in the notifications? For example, which members might be in the denominators?
I can take this. So we align to the HEDIS specifications for each measure. So for each of these measures, there's a place of service that the event has to occur in, generally either the inpatient setting or the emergency department setting. So that's the first thing we look for. The second thing we look for would be the diagnosis that came in for the reason for that admission or ED visit. So we follow the value set that NCQA provides for each of these measures. And we'll look. So if there is a mental illness diagnosis attached to an ED visit, that member would then go on our list. And we do that for each measure. We look at each value set, we look at each place of service, and that's how we identify each measure. So perfectly aligning with the HEDIS specifications. It's not perfect, I will say that. We do know that there are exclusions that come into play that we're not able to account for. But we explain that to our providers. They know that this is not going to align one-to-one with the end of the year denominator, but we do our best to, like I said, iterate on the process to make sure we're getting as close to it as we can. And we also we would rather overshare than undershare, because members getting care is never a bad thing. So whether it aligns with HEDIS or not, our main focus is always going to be member care.
Right. Does HealthShare work only on New York market?
HealthShare works everywhere. As a matter of fact, we have HealthShare working in markets outside of the U.S. So it's, again, what we need is to partner, like with Healthfirst, so to use our data platform with the, whether it's via an HIE, public or private, but to take advantage of those clinical data streams.
Next question is asking, what kicks off the email notification?
We run a series of queries on a daily basis to identify all of the qualifying events for the different measures. So that's really what kickstarts the entire process. Is we run those queries, we identify the events, we then do what we call the splits, which is figuring out which events go to which provider. And then every provider who ends up with one or more events, where we need to notify, that's really what kicks off the email. So not every provider will get an email every day. They only get the email if there's a qualifying event.
Right, let's look at the next question. Do you vary the information included in your auto alerts by patient and or provider type, and how did you decide this?
I think I could take that. We do not, well, primarily this information is going to hospitals and or PCPs. So we do not vary the information that goes based on provider type. They will all get the same level of information. Where we do vary that information is within the measure. So for FUA and FUM, it's very important that there's a diagnosis included in the information we share. Whereas with TRC, it's really all inpatient events for Medicare members, so a diagnosis is not as important to send along. But what is important for every measure is the admission date and the discharge date, if we have that, so they know when that 7 and 30-day window occurs. So we did look at each measure to make sure that we have the right amount of information included on each report. They're not identical, but they are very similar, and we set them up as similar as possible so that all of our providers go into the report, they know exactly what they're looking at.
All right, person's asking, do you guys work along with the patients to receive updates on their care?
We do have a care management team that does transition of care calls after every inpatient and ED visit. So while that care manager may not be working alongside the provider and the member, we do have providers working with the member, we have care managers. So we are taking a two-prong approach to this to ensure that somebody is hopefully getting a hold of the member post-event.
Yeah, and I don't know how broad that question is. If it goes to the platform, and I'm just perhaps reading things into the question, but yes, we support APIs for the patients to use third-party apps to get their information that's in a plan, a longitudinal health record.
All right, this question is asking, or any additional guidance that you may have beyond Collaborate on alerts more versus less likely to trigger provider follow-through?
Could you repeat the question? Sorry.
Sure. Any additional guidance beyond Collaborate on alerts more versus less likely to trigger provider follow-through?
I'll try and take this one, and if Kate or Stephen, you have anything to add.
Sure.
The one thing that we do that really enhances our collaboration with providers beyond our value-based agreements is we do have, excuse me, a provider incentive program, which all of these measures are included in. So that also enhances their the encouragement of them to collaborate with us and to utilize these reports. I think many payers have a performance or provider, incentive program, whatever it is called. So aligning the measures that you're sending reports out with the measures that are in your incentive program are really going to help you get the most attention to these reports.
We'll take turns. I'm going to add one more thing. I think we've tackled this from many different angles, actually. And I think one, going through this incremental measurement and sort of, iterating on this process, one of the changes that we made a couple of years ago was actually to include the patient's contact information that was provided by the discharging facility. And I think that was actually a really big bonus that helped with provider follow-through just around contacting the member. Because practices may not have the most current contact information for the member, but the admitting hospital would have. And so that was another ad that we included on the report, and I think helped.
I think just generally the question of keeping your eye on when is more, when is less more. I think in quality, we're always tempted to try to, if we have the information, to provide more information. And I think we obviously all want to move forward to doing more and more within the electronic workflow through the EHR. And Kate and Autumn alluded to it time and again, that it's really important to meet your providers where they're at. So I laud Kate's aspiration to get more and more of this into the EHR, but it's also really, really important to understand what the existing workflow for your providers, and I don't mean Healthfirst, yours, who's ever listening, your providers are at. If they're still largely working through email, you don't want to get too far out in front of them. And it's the same thing. Don't lose sight of what the original purpose of the alert is. You don't want to weigh it down with so much information. Then it becomes too time consuming for the care manager on the other side to pull it out. So just, yes, oftentimes in healthcare with this stuff, less is more.
All right, looks like we have another question in here asking, how does 42 CFR impact the work?
I can take that one. This is a great question, actually, one that we discuss on a regular basis. So 42 CFR Part 2, for those of you who aren't familiar with it, is the federal law around disclosure of substance use data, and it really applies to organizations who receive Part 2 funding. This is a challenge, I think, certainly with the mental health and substance use measures, where we know we are not getting all of the information to identify all of the events. And it is because some of these diagnoses cannot be shared. So that's a challenge, really not one that we can do a whole lot about. But what we do is we measure who is sending us these sensitive or substance use mental health diagnoses from non-Part 2 organizations, and we make sure that they are sending us all of that information. And I think some organizations have maybe some hesitancy to share that information, even though legally they don't have the same restriction that a Part 2 organization will have. And so we do some outreach and education to let them know that they can send us that information. We're very transparent about how we use it. And we've been able to historically get some organizations to more freely share that information. I do know also that there has been, there are some changes to the federal policy around Part 2 data. I think we were hopeful that would actually free up the flow of this substance use data. Unfortunately, I do think the way that it was designed, around execution, I think it's not going to be as easy to increase the amount of data flowing around that, unfortunately. But we're actually still working through sort of understanding the new provisions of that law and figuring out how it's going to impact these reports.
All right, it looks like all the questions have been addressed. I'm sorry. Go ahead.
No, that's okay. I was just saying that's a great question. It's very relevant to this program.
All right, so I'll send it back to you for any final thoughts since we got to all the questions.
I just wanted to add really quick to what Kate said with the substance use and the privacy issues. There's one of the reasons that we did, additional reason we developed this, because we are unable to send that information back to PCPs. So we are able to send it back to the servicing provider, the provider of care. So it was, I will reiterate, a great question, because it was one of the barriers that we needed to solve when developing this program.
I just wanted to say thank you for the great questions. Thank you for giving us some time in the middle of what I know is probably a hectic Tuesday for everyone. And just also, great questions, but I don't want to lose sight of where we started. And that disproportionately these time-sensitive HEDIS measures, they are trying to prompt care in what is a necessary small window for really high-risk members. So I hope we've motivated some of you all to think about what you can do with your clinical data streams to actually give your providers enough time to provide that care. And I guess, Kate, that leaves you with the last word.
Oh, well, actually, I think we have a new question that came in, actually.
Yeah, you're right. That one just popped in there. So before you go ahead and give your closing, I'll go ahead with this question. Could you please talk a little bit more about the data that you're pulling from the HIE? Is all the data available in the ADT, or do you need to look in additional tables to get all the needed data?
So good question. So for this particular program, well, I'll first off say we ingest all of the data that comes into the ADT. Not every ADT is created equal. Sometimes we'll just get notification of a admission or discharge, and there's no diagnoses in there. Some organizations will send an ADT from their registration system and not their clinical system. So there's a little bit of variance in the kind of data that we get. So, but basically, we will ingest everything that we have. And this entire program really is triggered off of ADTs. We do get some clinical information from other sources that come into our HIE, but it comes in with too much of a lag to be able to fold into this particular program. So I'm not sure if that answers the question, but we don't reference for this program. We don't reference any other tables beyond, the encounter data that we get through the HIE.
All right. So, Katie, did you have any of those final comments you wanted to bring in before we wrap?
Well, no, I think my colleagues have pretty much said it all, but I'll just add that I think HIEs provide a tremendous opportunity to really engage and react quickly to our members. And today we're talking about quality events and talking about emailing providers, but it goes well beyond that to be able to help with to help with care management, to really have our fingers on the pulse of what's going on with our members. A lot of this information comes in within an hour of the activity taking place. And so we are really able to quickly respond to our members' needs. And I think this program is one example of many. And the HIE has been a very valuable tool for us.
Right. To our speakers, thank you so much, all of you. We appreciated your time. Thanks, everybody, for sharing your thoughts and questions, to the audience for participating in today's webinar. And this does conclude today's presentation. Thanks again for joining, and enjoy the rest of your day.